Right. Good evening, everybody. We're going to have a run through some aspects of examination of the wrist and some tests that we think are important and sometimes not easy to do and not easy to interpret. I think one thing that's very important is to have be systematic when you are assessing the wrist. And the way I was brought up to do it is called the Apley way, after Mr. Apley wrote the book of orthopedics. And if you take your history, you do your examination, and in your examination, you look, feel, move, and then you do your clinical test. And then after that, you do investigations that you need. Maybe you need radiographs or ultrasound scan or MRI scan. Now, sometimes it's tempting to do the test first, and that saves you time and focuses examination. But that has a problem, and that's called confirmation bias. Confirmation bias is a cognitive bias where if somebody tells you the result of something, you're going to be looking for that, and then you are more likely to find that. Okay, so if you look at the MRI and says this patient has a TFCC tear, you're going to examine much more carefully the DRUJ, not very carefully the scaphoid because you know it's not going to be there, and then you get to the wrong diagnosis. So stick to the method and stick to the right order. Don't send the patient for investigation before you see them. Then the next thing, you need to be clear why patients are coming to see you. And they come to see you because they've got pain, they've got clicking, clunking, swelling, because they're stiff, because they're weak, because they cannot do their job. And it's important to understand the mechanism of injury. You cannot just say, oh, they had a fall. If you fall forwards on your outstretched hand, your forearm will be pronated. You are more likely to land on the ulnar side of the wrist, and that will determine what injury you get. If you are a 12-year-old boy, you'll get an epiphyseal injury. If you are a 70-year-old lady, you'll get a distal radial fracture. If you're a 25-year-old man, you'll probably get a scaphoid fracture. So it depends on the mechanics and the patient, but that tells you a lot. It's important to know when, where, and how it happened. In my practice, patients usually say, oh, I had a fall about 6 months ago and it's still painful. If they say the exact date and the time, it usually means that there is an issue with it. They have an issue at work, or they have a legal case, or they've written it to the solicitors or something like that. So just ask them. I ask them straight, you know, do you have a case or what's happening with work? And they're usually quite open about that. So in the middle of busy clinic, you have a patient with wrist pain, and sometimes you have a sinking feeling. You say, well, am I going to get anywhere? And the thing to do is put it in the right box. If somebody comes with swelling, all the joints involved, systemic symptoms, the skin conditions, that's going to be an inflammatory cause, rheumatoid or psoriatic or something. If somebody comes with wrist pain after a clear injury, and I mean a significant injury with clicking, mild swelling, the pain is worse during and after activity, and the patient can demonstrate the clicking or can demonstrate what happened, that's mechanical. And that's the one we'll mainly focus on today. If somebody comes and they've got pain at rest, that's not related to activity, pain at night that wake them up, pins and needles or paresthesia, numbness, that's likely to be neurological pain. And conditions like carpal tunnel or thoracic outlet can present with wrist pain. So be aware of that. And then if they had the pain for quite a while, but they didn't do anything about it, progressing slowly, grating, stiffness, deformity, that's degenerative usually. But bear in mind that a vascular necrosis sometimes presents like that. Somebody who's lost movement, particularly lost passive flexion, without a clear history of trauma, always wonder if they've had an avascular necrosis like Kienbocks or rarely Preiser disease. And also bear in mind that 1/3 of patients refer to us with a wrist problem. The problem is not in the wrist joint, it's around the wrist joint. It's in the tendons, like in the curve ends, or will be a nerve like carpal tunnel, or a compression of the radial nerve, Rothenberg's. So just be aware that there's a wide range of diagnoses here. And once you put them in the box, focus your examination there. And then the method we follow is this: look, feel, move, and then special test. And what you're looking is big things like swelling, scars, redness, excuse me, but also the subtle things. Like on the dorsum of the wrist, if there is some swelling, you'll see it clearly. On the volar side, it's more difficult to see. What you'll see is that the volar creases don't look the same than the other side. They are less obvious. Look at the head of the ulna. That will be important. And look at the hand both in pronation and supination. And to examine a wrist, you really need a table, and you need to put the arm of the patient vertical. You need to be able to move it. You need to be able to feel it, and you need to get them to relax the muscles. So for example, if you look at this lady, came to see me because she had a fall a few months before onto the right hand, and the wrist became painful. She was told that the radiographs were normal. Can you see anything abnormal? If you look carefully, the head of the ulna on the right looks more prominent than the left. And I think once you notice that, it's quite obvious. And that is going to give us the clue to the diagnosis. We'll come back to that. So then you need to feel the wrist and try to find where the pain comes from. If you find the tender area, you are 50% there. You are nearly there. But you need to know what you're feeling. And you need to feel all these structures. And you need to know the surface anatomy to know where they are. So if you look at the dorsum of the wrist, you start looking at it, and you see this, but you need to visualize this actually. Yeah. And the easiest thing is start away from the pain and move towards the pain. If you press the area that's very painful, the patient loses confidence, tighten up, and it's more difficult. Yeah. And the easiest thing is start at the radial styloid, that's on that side. I was always told that just distal to that in the anatomical snuff box is the waist of the scaphoid. But if you look at it, it's more the STT joint. If you put the wrist in ulnar deviation, then you're pressing on the waist of the scaphoid. So when you examine for a scaphoid fracture, put the patient wrist in ulnar deviation, feel the scaphoid, and see if there is a difference with the other side. Then if you find Lister's tubercle here, just move your finger around like that, easy to find. Move it distally, you'll fall in a valley, and that's the scapholunate junction. Scapholunate ligament is there. You can flex the wrist a bit to have better access to it because most of it is under the radius. Ulnar to that is the lunate, a bit more ulnar is the luno-triquetral ligament. That's also an interesting area to feel. Then there is the triquetum. If you come proximal here, you'll be able to feel the distal radioulnar joint. If you are not sure, pronate and supinate the forearm a little bit, and you'll see where the gap is. And distal to the head of the ulna, you'll fall in a bit of a valley as well, and that's the dorsal band of the TFCC. You can also feel the TFCC from the ulnar side, but remember that you've got ECU here. Yeah, so you can feel the TFCC that side on the fovea or dorsal here. Yeah, and then if you move to the palmar side of the wrist, you're seeing this, but in your brain, you're visualizing this. And the wrist joint is a little bit more proximal than you think. People think that the wrist joint is in the hand, but it's not. Because if you think of it, where the creases are is where the movement is. So the creases are where the joints are. On the ulnar side here, under the distal crease, there's a lump that you can grab with 2 fingers, and you can move it side to side, but not proximal distal. That is the pisiform. Yeah. And pisiform problems are underdiagnosed, and they're very easy to examine. If you flex the wrist a little bit, it's easier to ballot the pisiform. And then from the pisiform towards proximal, there is the flexor carpi ulnaris tendon, and that can have his own sort of pathology. On the other side of the wrist, under the crease as well, is the distal pole of the scaphoid. You can feel that on your non-dominant wrist, and if you move your wrist towards ulnar deviation, it becomes less prominent because the scaphoid is extending. If you move it towards radial, that lump becomes more prominent because the scaphoid is flexing. So just next to it and towards proximal is the flexor carpi radialis tendon, which is another source of trouble and pathology. Distal to that is the STT joint, scaphotrapezium trapezoid there, and 1 centimeter distal is the carpometacarpal joint of the thumb. So knowing the surface anatomy, helps a lot. And there is no other way of learning it than practicing. So get familiar with all that. Practice with a colleague. You cannot examine your own wrist really. So you need to sit down with a colleague or a friend and examine them. Check the movement, active and passive of the patient, flexion extension, radial deviation, and pronosupination. Pronosupination is the one that catches you a bit because a patient try to trick you by moving their shoulder. It's like if you see this lady, they try to compensate because the end of branch is painful by internally and externally rotating the shoulder. So if you put the elbows next to their body, they cannot do that. And then you measure proper pronation and supination. And if you measure that, you need to measure it at the styloids, between the radial styloid and the ulnar styloid on one side and the other. Don't measure it looking at the hand, because as Marc was telling us recently, there is intercarpal pronation and intercarpal supination. And patients with the stiffness of the forearm will compensate with more rotation at the radiocarpal and midcarpal joints. So we're going to go through a provocation test for these 4 situations: scapholunate, luno-triquetral, midcarpal, and DRUJ. And we'll start with the scapholunate, which is the one that we all know. What is scapholunate instability? Well, this is it. That's what scapholunate ligament instability is. And this is a video from Dr. Ian Salva, hand surgeon in Palma, in Mallorca, and good friend, part of the Kaplan clan. And what happens in this situation is that the scaphoid and the lunate come apart, but the gap is not the issue. The issue is that the proximal pole of the scaphoid is subluxating dorsally on the dorsal rim of the radius. If you look at that, it's just about to pop out. And sometimes a patient can do it themselves. This is a case from Carlos Ibrisari, famous hand surgeon in Vigo in the north of Spain. And this patient could do this trick to show the scaphoid jumping. And if you ask them to do that in the other hand, you say, well, I cannot do it in the other hand. You say, well, try, see what happens. So he tries that and it doesn't happen. So this is unusual, but sometimes patients have a little trick to make it click. And you can ask them, can you make it click? And they'll say, yes, I do this, And I find that very helpful, because immediately you know if it's a wrist problem or it's a forearm problem. Another test that's interesting is the finger extension test. Now, this is a sensitive test, but not specific. You ask the patient to flex the wrist as much as they can, extend the fingers, and then resist that while you push down on the proximal phalanx. If they've got any problem on the dorsum of the wrist, a wrist fracture, scapholunate ligament, a ganglion, whatever, they'll tell you that hurts the wrist because you're putting a lot of force on it by doing that. If they say, no, that doesn't give me any pain, then they probably have not got a significant problem at the dorsum of the wrist. If they say, that hurts my fingers, then you're in a bad situation, because they're going to say yes to everything, because that shouldn't hurt the fingers. And then the Scaphoid shift or Watson test is the one that's most famous, and you should all be able to do this and understand what it means. So we've seen over the past few weeks that as the wrist goes into radial deviation, the scaphoid has got to get out of the way. And it does that by a combination of 2 things: sliding towards ulna on the radius and flexing. Yeah. And some scaphoids do more of one, some scaphoids do more of the other. And that's from Marc's webinar from the other day. You can find this on YouTube, on pulvitar videos, on anatomy and biomechanics of the wrist, and it's very well explained why and how this happens. So just remember, inflection, scaphoid cause inflection in radial deviation, in extension, in ulnar inclination, and it does that passively because it has no tendons attached to it. So if you bring the wrist from radial to ulnar, the scaphoid will flex. If you try to resist that, and the scaphoid has intact ligaments, the scaphoid will push hard against your thumb. But if the ligaments are not intact, the scaphoid will not be able to push hard, and then it will subluxate dorsally. And if you have your index on the dorsum of the wrist at the scapholunate junction, you may feel a click, or you may feel the subluxation, or the patient may tell you what's happening. So the way you do this is you take the wrist ulna, resist, resist the flexion of the scaphoid, have an index finger on the dorsum, feeling the scapholunate ligament, and see what happens. And don't record this as positive or negative. Say, doing a Watson test causes pain, or the patient feels a click, or I can feel a click, or I can feel a subluxation. That's much more specific. Yeah. And when you do under fluoroscopy, that's what happens. If you look at the dorsum of the wrist, you can just see the proximal ball of the scaphoid that rides on the rim and falls back in. Yeah. You can see just there. And I think what happens in patients is something slightly different, is this, that the patient flexes there and the scaphoid subluxates and then so plunk there and falls back in. Yeah. So subluxate and go plunk, and I think that's the plunk that the patient feels is a relocation plunk, and that will happen going from radial to ulnar flexion extension or when gripping. So what does that mean if it's positive? Well, there are two studies on that. One was done by Kerr Watson, and after excluding all the bilateral positive ones, 21% of symptomatic volunteers were still positive on one side. So having a click when doing a Watson test is not that uncommon, and is not very specific. And another studies by Scott Wolf, and 36% of normal subjects have a positive test altogether. So not so specific, but sensitive. And then you need to interpret that in context with the history and what the patient wanted. I'm going to stop sharing now. And what I would like to do is maybe Alex first. Alex, would you give us any comments or any tips on examining the scaphoid or the scapholunate?
Well, I think you explained it quite well. Maybe just a couple of things, because the problem is that patients with scapholunate injuries, they can come with a wide spectrum of presentation. So some of them, they are just painful but not unstable, and the other ones maybe also on the other side even arthritic. One thing that maybe it's interesting, it's the video you showed from Scott Wolf, in which you place the wrist in flexion and extension, and you were looking for the dorsal displacement of the proximal scaphoid. It's tried to reproduce that with a couple of ballotment tests. You can press the scaphoid from the volar side when you place the wrist in flexion, and you can press on the dorsum of the wrist, or either on the radius or in the lunate, and try to make what you have shown on the fluoroscan a little bit more evident, trying to induce the dorsal translation of the scaphoid a little bit more evidence. You can call that the radiolunate or the the scapholunate or the scapholradial ballotment test, and I think that can be useful also. And I completely agree with the fact that the Watson test, it's not so easy to get, and it's not so easy to get as dorsal subluxation, but many times what you got is pain, and you have also to compare it to the other side.
Thanks, Alex. Mark, any comments from you?
Yeah, I had two comments. One is when passively mobilizing the wrist, you may mobilize along the flexion extension plane, or you can also test the patient for mobilization of to the dart throwing and the reverse dart throwing plane. By doing so, you may almost be certain that the pain comes from either the radiocarpal or the midcarpal joint, or to both. It's just easy. Just going into the plane of extension radial deviation to flexional deviation. You know that for certain, it's not exactly, but you know for certain that you are basically mobilizing the midcarpal joint. However, if you go into flexion radial deviation into extension ulnar deviation, you are mobilizing basically the radiocarpal joint. So by doing this, this is a trick I use to know where the problem is. If the problem is midcarpal, you'll have more problems or you'll have more pain into the dart throwing plane. The second comment I want to make, it's in the line of Alex's comment on this. Remember that with Watson test, we are not specifically testing for scaphoid dissociation. If you have a very flat distal radius, for instance, sometimes you have a subluxation of the scaphoid plus the lunate. And even if the guy has a lot of laxity, then you may have a positive test, very painful, but this is not positive in the sense of mechanics. So be careful with the Scaphoid Shift test because it clunks, it clicks and produces snaps. Sometimes that they are just something bilateral. But needless to say, you have said that we need always to compare to the contralateral side, and this is it. Other than that, I think you presented very well, so no further comment on that.
Thank you, Alex.
Yes, one thing that you have said, and we have seen it a couple of times, it's a clank, but it doesn't come from a midcarpal problem, but it comes from a scapholonate problem. And I think that's interesting because all of you may see patients like this. So when you see a clanking wrist, see if it clanks from radial to ulnar inclination or if it clanks from flexion to extension. Because if it clanks from flexion to extension, probably it's a problem affecting the scapholonate interval. And something related with Marc's comment, remember that when you do the dart throwing motion, the proximal row, it's not moving unless it's at the ends of the motion and unless you don't have a true scapholonate instability. And in those cases, patients may feel more comfort if they are clearly unstable. If you hold the scaphoid, you try to do a dart throwing motion, but you try to hold the scaphoid, especially from the volar side with the thumb, or maybe from the volar and the dorsal side, and then try to reproduce the dart throwing motion. So if they have a true scapholonate instability, it will be no so let's say painless when you do the dart throwing motion, but when you hold the scaphoid, then it will become much more comfortable for the patient. And always do everything comparatively, as you said. Yeah.
That's a good point. One thing that I think the patients understand, if they click, what I said, is the clicking to do with this, exactly, or to do with this?
Exactly.
And they'll tell you, if it's to do with this, that's going to be a DRUJ or a forearm problem. If it's to do with this, it's going to be a midcarpal issue. If it's to do with this, could be several things, but it could be scapholonate. We'll crack on, and we'll move on to luno-triquetral instability. And what is luno-triquetral instability? That's another video from DM, who is today in the audience. Very nice for him to join us, and we have learned a lot from him. And that's what happens. So that's a cadaveric preparation, and you can see the scaphoid and the lunate going parallelly while the triquetrum stays there. So there is a long list of tests to test for this, but we'll have a look at the first three of those, I think. And the shack test is when you grab with one hand the triquetrum and the pisiform, and with the other hand you grab the lunate, and you ballot them or shack them. And this was described by Regan. Sometimes it's referred as Regan's test. A variant of this, a bit more refined, was described by Bill Kleiman from Indianapolis, the Indiana Hand Center. And this is called a shear test. So all you do is you put the thumb under the pisiform to push the triquetrum dorsally. You put your index finger on the dorsum of the lunate, and you create the shear force and see if that reproduces the click or the pain that the patient feels. It's always important to ask the patient when you elicit a click, is this the click you get? And sometimes it is, and sometimes they say, no, I never felt that, you know, and I reassure them that everybody's with click when they come to see me. Just a matter of finding the click that they have. And then a third test was described by Chris Bembridge, who's one of my colleagues in Derby over 20 years ago, and Loisos Christodoulou, who was one of the fellows, a good colleague of mine as well. And that's what is done is you extend the wrist, support the triquetrum by pushing the pisiform dorsally, and then bring the wrist to neutral to put the carpus on top of the triquetrum if you want, and then the patient will tell you that while you're supporting the pisiform and the triquetrum there, it feels better. And then a further variation that we've done from that, again, Chris Bembridge's idea was to do the test with the JMA dynamometer in the hand. So you get them to do a grip with the forearm vertical, dynamometer in the hand like that, get them to do a grip, then bring the wrist dorsally, realign it, and get them to grip again. And if it's a true luno-triquetral, when you support it, the strength usually doubles. And that persuades the patient and persuades you that that's what it is. And I find that quite useful. So before we go any further, again, I'm going to give Alex and Marc an option to give us their benefit. Which tests do you use to diagnose luno-triquetral instability, or what are your favorite ones? Marc, you want to start on that one?
Now, I usually ballot almost all the joints, and luno-triquetral joint is one that is specific for that shock test. Whether you use the two hands or one hand, it's under. I don't think has any problem. But going back to what I say in the last session on ulnar side instabilities, remember that if I can mobilize the luno-triquetral joint, but I can also mobilize the midcarpal joint. It's just a matter of having the grip on the pisiform and the triquetrum here. If I mobilize that by blocking the rest, then probably I'm mobilizing the luno-triquetral joint. But if not, I can mobilize the midcarpal joint, and it's just a matter of grasping the rest of the carpus while you are mobilizing. It's difficult probably to say like this, but certainly you can mobilize individually with some training. You can mobilize individually the two joints, either luno-triquetral, and in this case we are setting a dissociative problem, or you can mobilize the triquetral hamate capitate ligament, eye articulation.
Thanks for that, Marc. Alex.
Honestly, I try to mobilize the luno-triquetral joint, but sometimes it's not so easy. When it's really lax and the patient is really relaxed, it seems to be very easy, but it's not so easy. This is why I find the relocation test a little bit more easy. And I think what you've mentioned about using the dynamometer is extremely helpful in any type of instability problem. I think this is very useful. And another thing that I try to do, but I know I'm not successful many times, it's as you will probably mention later, try to do the exploration in neutral or a little bit of ulnar inclination and repeat it in radial inclination, trying to have the ulnocarpal ligament a little bit tighter and see if it changes a little bit.
Yeah, I'll just tell you one more thing about this. When they were writing the article, I was a fellow in Derby in those days, and I went to Chris Bembridge and I said, Chris, I'm really impressed with this. You know, you work out the mechanics of this really nicely. And he said, no, I don't understand the mechanics of this. And I said, well, how did you write the paper? I said, well, one of our nurses in clinic has luno-triquetral instability, and she does that and makes it click, and then it feels so much better afterwards, you know. And from there, he said, well, that's a diagnostic test. And we asked a few patients, and one thing I always ask them, can you make it click? And they say, oh yeah, I do this. Yeah? And they relocated themselves. And they say, and then it feels better for a while. So sometimes it's very easy to diagnose from the history more than the examination. And if they learn to do that, it relieves them for a while. But going back to what Marc was saying, we'll move on to the midcarpal. And Marc spoke about non-dissociative instability recently. And this is a risk that comes with a clunk, and sometimes they can clunk it themselves. Oops, sorry. Let me go back to that one. And if you look at the lateral view there, you can see that there is a palmar sac. So the hand is lower than the forearm, and then that's because the proximal row is flexed. So the distal row is lower than it should be, and it remains flexed till the end of ulnar deviation. And then it catches up, the whole of the proximal row jumps from flexion to extension with a clunk. So it's a catch-up clunk, yeah? And you can do it yourself passively, instead of the patient doing actively. And that's a patient that's surgery to show that the whole proximal row jumps as you do that, and it doesn't dissociate. So it's a non-dissociative instability. So if you do it on the fluoroscan, you can see that the lunate, but also the scaphoid and the tracheatum are flexed in radial deviation. And as you go towards ulnar deviation, in the end, they jump into extension. So it sort of reduces itself. And that's a catch-up climb for a palmar midcarpal instability. And if you look at it on the PA, you can just see that the whole of the proximal row jumps from flexion into extension as it gets to the end of ulnar deviation. One little detail when you do the fluoroscopy, when the proximal row is flexed, the scapholunate gap looks a bit bigger, but that's a projectional thing. That's not the scapholunate instability. Because sometimes people screen them and they said, oh, in radial deviation, you get a gap. But it is not that, it's just projectional. So don't let that confuse you. And David Litchman from Dallas-Fort Worth devised this test where you passively push the hand down to create a palmar sac, bring it to ulnar deviation, and at the end of ulnar deviation, it will jump back or not. And what he developed is a grading. So if you do that, take the wrist with downward pressure and nothing happens, that's a grade 1. If you get a minimal click, that's a 2. Click that you can sort of hear is a 3, a very big plunk, or the wrist stays subluxated palmally. Should you push it back or the patient contract the muscle, that would be 4. And if you don't have to do anything at all, the patient comes and they do it themselves, that's a 5. And Marc quoted that line from Bill Cooney that said that patients do this to the amusement of friends and consternation of doctors, because they do it as a party trick and they show their friends. And the more they do it, the laxer they get, and the more it happens. And then they complain about that. So I'm going to go back to Marc and Alex again. Any other things we should do to better define this type of instability, Marc?
Well, I think that it is important to test for increased mobility, but also for pain. Pain, it's not, regardless what we have said about scapholonate, scaphoid test. The midcarpal joint, it may be painful and produce the click and the clank. But the important thing is that if we are testing for hypermobility, we can have exactly the same midcarpal test positive, and yet not to have pain. Well, in other cases, you do that with an STT, for instance, an STT osteoarthritis, and it may be so painful that the patient has learned that that doctor is going to produce pain, and they block this with their muscle. And we need to understand this, that the muscle is extremely important, and we need to do the test in a way that we are not harming the patient. Because if they know that it's going to hurt, and you do that the first test, then they will never allow you to do the rest of the examination. So what I'm trying to say is that we should be careful with the pain producing. The pain may come from an old tissue, an old intervention, an old osteoarthritis thing. So be careful with that. Not to search a pain as the result.
Yeah.
The pain is a negative thing in a way. Mm-hmm.
Well, interestingly, I did have opportunity to discuss that with David Litchman, and we were sitting at the back of an auditorium at the FESH meeting, and he was examining my wrist, and I was examining his to compare what we do. And he's very, very gentle, actually. He made the point of being very gentle, and we're just having a chat. And we didn't realize the session had finished, so he was holding my hand and doing all that kind of thing. And we were just engrossed in the discussion of what it really meant. And then we realized we're surrounded by people watching us. And he looked up and just suddenly threw my hand away and said, "We're just good friends, nothing going on here, you know." But he was very gentle. What some people doing the Watson test, they're very forceful, which I'm not. I think you need to be very careful. That's a very good point. Don't try not to hurt the patient. Yeah. Alex, any comment from you?
Yeah, but midcarpal or palmar midcarpal. If you see a patient which is coming with a wrist which is radially inclinated and with the sac, this has to be your first suspicion, because they try not to bring the wrist towards the ulnar side because they know it will clank. And if they refer pain, not only the clank, it will be an ulnar sided pain. This is something. One thing that I have seen also, it's, I don't know how to call it into the Litchman's classification, it's an static flexion of the proximal row. And this has, all the times that I have seen it, it's related to hyperlaxity syndromes like Ehlers-Danlos or patients like that. They may come with a static flexion of the proximal row. And regarding the exam, remember two things. One is, if you place the forearm in supination, that means that your ECU is going to be more effective, trying to bring the distal row and forcing the proximal row not to be in flexion but in extension. You will be, or probably your reduction of the proximal row will be more successful. So try to repeat the test in forearm pronation and supination, and probably in supination you will be more successful. And then also try to relocate the triquetrum, because it's easy by pushing the triquetrum to bring the proximal row in extension.
That corrects it. We're going to move on and talk a little bit about tests for the DRUJ problems, and that's the whole chapter in itself, actually. So radial ballotment is when you move the radius relative to the ulna. A weighted test is based on the observation that if you load in full extension and you rotate, that's very painful. And it's called weighted states because of the way weight carries a tray. Nobody has come to my clinic and said, I cannot carry a tray. Men usually says, I cannot do press-ups, I cannot do push-ups when I go to the gym. And women say, I cannot push a door open, or I cannot do tasks that involve pushing down. Another test is the push down. If you get the patient to put the hand on the table and you push down, the ulna will depress. And then there are tests for abutment, ulnar deviation, and rotation, and the pisiform boost test that I quite like. But I want to concentrate now on radial ballotment. This is not a patient. This is Helen. If I grab with one hand the radius and the hand of the patient, with the forearm vertical and their muscles relax, with the other hand, I grab the ulna, I can move it. In ulnar deviation, the ulno carpal ligaments that don't come from the ulna, they come from the TFCC, are more relaxed, then I'm getting a bit more movement. And as I put it into radial deviation, I put the patient wrist into radial deviation, make sure their muscles are relaxed, that will tighten up and there'll be much less movement. Yeah. And then I'll compare this to the other side, to the good side as well. So that tightening, my impression is that 95% of the time is what the TFCC is doing. So that gives me a good idea of the state of the TFCC. If you take the wrist into full supination, then the volar capsule becomes a stabilizer. Into full pronation, the dorsal capsule becomes a stabilizer. So you're getting more structures into play, and it's a bit more complicated than that. But this is a patient, so you can do two things. With the wrist in ulnar deviation, there is much more movement. And if I put it into radial deviation to tighten the TFCC, there is still the same movement. So to me, that's in an unstable DRUJ. It could be because there is a problem with the bone, like a malunion of the radius, or because there is a torn TFCC, or because there is a bigger problem in the forearm. One thing I was going to show you here is that if you do it in a patient that's relaxed, like this patient has had a block, then the movement you get is even much more marked. So it's always useful, just before you start an operation, re-examining the wrist and the anesthetic. And you'll see like every sign is exaggerated because they've been protecting it with the muscles. Yeah. So that was another TFCC there, about to have an arthroscopy. So I'm just going to show you this case to see how the system works. This is a 42-year-old lady, had a fall 6 months ago, pain in the right wrist, went to the accident and emergency department, had some x-rays. They told her she was fine. She probably had a sprain and that will settle. But 6 months later, is not settled. She gets clicking, and she tells me that the clicking is when doing this. And the radiographs are normal. So what you can see there, just by looking at it, is that the ulnar head on the right is more prominent than the left. Yeah. So if we try this test on the good side, so the left side is the normal side, she will have a little bit of movement of the DRUJ. Yeah, I can ballot the ulna a little bit. And then if I try it on in radial deviation, that tightens up, trying to push it and not getting hardly any wobble. Yeah. If I do this on the right side, which is the painful one, then what we'll see is that there is a lot of movement both in radial deviation and in ulnar deviation. So to me, this is an unstable DRUJ. The radiographs are normal, therefore likely to be a TFCC problem. So all I do is I'll offer her an arthroscopy and bring her into the hospital, have an arthroscopy. That's the arthroscopy from the 3-4 portal. You can see the TFCC. If I push with the hook on the TFCC, it should feel like a trampoline, but this one actually feels like a pillow. And then there is a tear there. I can put the hook underneath and lift it up. So that's a peripheral detachment that explains the symptoms. And I'll open it up because it was quite gross and fix it, and she did very well. So my main message is you need to develop your own system. The only way to do it is learn to do the test and practice them, see which ones work for you, look, pull, peel, move, special test, and then do the special test. Things that I find very helpful is screening and image intensifier. You can see 3 views here, one a static X-ray that looks normal, the other one in normal deviation. You can see a gap between the scaphoid and lunate, and the third one is with the grip, and you can see the scaphoid flex in there. We have a fluoroscopy in our patients, and I find that extremely helpful. And the other trick is use injections of local anesthetic, very small amounts, 0.5 ml to 1 ml. Where you think the pain comes from. If you put a bit of local anesthetic, leave the patient for 20 minutes, see them again, the pain is gone, you found the origin of the pain. And then just emphasize what Marc and Alex were saying. The examination has to be thorough, systematic, and bilateral. That's why most patients have 2 hands, 2 wrists, so you can compare them. The previous tags I've referred to, you can find them on YouTube, put Pulvertab videos, you'll see the whole collection there. And it's good now and then to go back and look at the anatomy and the mechanics to understand all this. And I'll leave you with a quote from Dr. Kerr Watson: the clinical exam is everything. And I do believe that. So, Marc and Alex, any comments on the DRUJ examination?
Yes, I think that we should be aware that we are examining not the DRUJ. We are examining DRUJ and ulnocarpal joints. That means that in the domain of an ulnocarpal abutment, all these ballotment tests may be extremely painful. Coming back to the pain, the relationship between pain on one side and hypermobility on the other side. Remember that in neutral position, everybody can ballot a little bit, but it's in maximum flexion, maximum supination or pronation, when all these elements, not only ligaments, but also the muscles, those are the ones we are testing. So in fact, to have a little mobility in neutral position, it may be acceptable, but it's not acceptable if that same mobility, or if there is increased mobility in full flexion and full pronation and supination. And in that sense, I would like Mireia Splugas, whenever she will come to tell us about the arthroscopy, to give us some impressions, some new ideas that she's getting from her PhD on the influence of pronation and supination of the forearm on carpal pathology. Because sometimes if we don't understand that, there will be always some test that we will imagine that is positive or negative. And the influence of the forearm needs to be included in all these examination, wrist examination.
I'm gonna get Mireia, see if she can join us. Because she's made the comment on examination, but I don't quite understand it. So we'll get her to explain it. Mireia, you want to join us and tell us?
Hello.
Good evening. Thanks for that. You are muted at the moment.
Good evening. Hello.
Good evening. So, sorry, caught you by surprise there.
My comment was on SL instability. What I really find interesting and explain me what the patient feels is that I ask him to make a fist and to feel how the loading is transmitted across his wrist to his forearm, and then I doesn't allow the scaphoid to flex under the load, and I ask him to tell me if he feels better, if he feels stronger, and if the scapholunate ligament is incompetent, they feel they are better. And I have always done it with the jammer, and it's not a big increase of strength, but there is any. And
So it's like the relocation test, but on the radial side.
that's right. It's
Okay.
avoiding the scaphoid to flex under load.
Yeah, that seems a very reasonable idea, actually.
Okay, and then with DRUJ, I love the pulse-imperator device, which allows me to test the DRUJ stability under the load. I always put 2 kilos, and I ask them to be neutral. If it's painful, it explains me some DRUJ arthropathy, and then I ask them first in the normal one, and then in the non-normal one, and to tell me if they, when they supinate under load or they pronate under load, if they feel pain, where they feel pain, and then I put them a wrist widget, and I ask them to do it again. And if the DRUJ ligaments are incompetent, they feel worse under load with the pronosupinator.
Thank you. Guys, all the attendants, if two things. Before you leave, please fill in the feedback questionnaire. If you want to register for the webinar next week, I put the link on the chat. And if you want to ask any questions, please put them in the Q&A. We're not going to be very long, but we may have time for one or two questions. Alex.
Yes, one thing that it's also I think it's useful in ulnar-sided pain, especially when you think that you have a TFCC pathology and maybe your ballotment test is not so clear as the cases you showed. It's to do a kind of press test, but with a dynamometer on the table. So you can quantify the amount of loading that the patient can do and then compare it to the other side. So you place the dynamometer on the table and you make the patient press and see when it's painful and see the amount of kilograms that you need for in order to get the pain. You compare it to the other side, and then you can do an injection with anesthetic and see if the amount of loading it's increased. So I think this is quite useful.
Yeah, that's always useful. When if you manage to abolish the pain, test the strength again and see what the difference is with that.
And I don't know if it's useful for anybody in the clinical practice, but if I see that the patient can understand what you're saying, I always start when I'm exploring an ulnar-sided pain, saying three things to the patient. The first one is, in such a small area, we have around 35 sources of pain. So it may be difficult to see where your pain is coming from. This is the first thing. The second thing that I tell them, this is an area which is extremely well innervated. So you don't need to have a very big lesion to have a lot of pain. And I think this is useful. And on the other side, I also tell them that if a small lesion can be painful, that means that if you have a small lesion, it can heal without doing a lot of things. And most of them, they start the explanation by understanding that, and that makes things a little bit more easier.